عليكم. Inshallah, today we will talk about meniscal injuries. We will start by anatomy. Histology mainly formed of type 1 collagen fibrochondrocyte. This is the collagen arranged in the peripheral in a circumferential manner, and there is radially oriented fibers. This radial acting as a tie to hold this circumferential together are responsible for what is called hoop mechanism. In between there is medial perforating fibers and chondrocyte. Fibrochondrocyte is responsible for the healing of the meniscus into fibro cartilage. So this circumferential fibers, longitudinally oriented fiber, is held by a radially oriented fibers. Together are responsible for the hoop mechanism, which resist the axial and load compressive force to converting it into a tensile force. This is the hoop mechanism, the same as in the lumbar disc. Lateral meniscus, more circular. This is the lateral meniscus. This is the anterior horn, beside in direct relation to the posterior horn, so it is circular. In comparison, this is the medial meniscus. The anterior horn is farthest away from the posterior. ACL is little bit anterior and medial. Lateral meniscus is circular, anterior to posterior. So if you want, theoretically, if you want to transplant the lateral meniscus by autograft, you can use bone bridge like this. This is a bone bridge because the anterior is in close relation to the posterior. But if you want to transplant the medial meniscus, you will use a plug. You can't use a bone bridge because ACL is in between, like this. This is the this is the plug of the medial meniscus. This is the plug technique. More mobile. The medial meniscus here is attached to the capsule all over its radius, but here there is a popliteus tendon here, and there is a menisco-femoral ligaments attachment, ligament of Risberg and ligament of Humphrey in relation to the BCL, attach the lateral meniscus to the femoral condyle. This making the capsule loosely attached to the lateral meniscus and making it more mobile, so less susceptible to injury in comparison to the medial, except in two situations. We already take tibial plateau fractures, in which the lateral is more common than medial, so lateral meniscus injury is more common than the medial meniscal injury. And the second one we will take later, ACL injury. So in general, medial meniscal injury is more common than the lateral, except in two situations. And also for two reasons. One of them we already take, that the capsule attached loosely. Another one is the unlocking mechanism during flexion of the knee. Unlocking mechanism means internal rotation of the tibia and contraction of popliteus. This contraction withdraw the menisci to orient it during its rotation, so less susceptible to injury. Lateral meniscus is associated with discoid more than the medial, could be the source of pain. Okay, regarding the medial, is C-shaped. The anterior part is farthest away from the posterior horn. So if you want to do a transplant, you will use bone plug technique. More fixed, capsule is attached all over its length without intervening tendon or ligament as the lateral side, so more incidence of injury. There was associated with discoid lateral meniscus. Here, meniscal root injury. Meniscal root injury is mostly in the posterior horn of the medial meniscus. This is a complete disruption of circumferential and radial fiber. This is equal to total meniscectomy. You have to repair it once it is discovered. Menisci following the tibia anteriorly in extension and posteriorly in flexion, but follow the femur in rotation. Vascular blood supply from the medial and the lateral geniculate arteries, either superior or inferior, forming perimeniscal plexus. Here, supplying the outer, only the outer third of the menisci, forming red zone, red white zone, then white zone. So if you want to repair, you can repair in this zone, which with increased vascularity. Even if you have a vertical tear in this zone, you can, and it is small, you can manage it non-operatively. It will heal. It will heal. Here, there is a bad healing process either in with conservative or operative management. Function of menisci to fill joint filler, to fill the compensation between the relative flat surface of the tibia and the convex femoral side, so increasing the contact area. Shock absorption through hoop mechanism, dissipating the axial loads and converting these loads into tensile force. Joint lubrication and secondary stabilizer. Please review knee examination lecture. What is the difference between the anterior drawer testa and Lachman? Anterior drawer to avoid this door stopper effect. Secondary means that it's a secondary function when the primary function of the anterior translation is lost, and this is occur in ACL disruption. Basic sign, some basic sign MCQ. In extension, 50% of the weight can be transmitted through the meniscus. In flexion, it increased to 85%. Meniscal stiffness increase with higher deformation rate. This is a viscoelastic curve. Take it now. Keep in your mind now, and it will have we will have a separate lecture about the viscoelastic curve. Pathogenesis, we have traumatic and degenerative causes. In traumatic, the traumatic event will be a rotation of a flexed knee. In a young active, mostly associated with ACL, there is a rotational component, and mostly will result in vertical longitudinal tear. And this vertical longitudinal tear, if displaced and enlarged, it will convert into bucket handle. This is the longitudinal tear. If enlarged and displaced, it will be converted into bucket handle. Degenerative means non-traumatic. So usually there is no history of trauma. Usually it is more than 40 year, minimal healing potential, mostly horizontal, not a longitudinal tears. Natural history, all meniscal injury, especially if isolated, you have to give them non-operative management, trial of conservative, because most of them heal well. Meniscectomy, lateral meniscectomy is much more worse than the medial meniscectomy. It increases the contact stresses 2 to 3 folds. Classification, a lot of classification types according to location, type of tear, and the etiology. According to the shape, longitudinal tears, longitudinally oriented tears, transversally oriented tear, or combination of both, or tears associated with meniscal cyst or discoid meniscus as a source of pain. For example, this is the longitudinal, if displaced the bucket handle. This is the radial orientation. This is horizontal. and this is the flap, parrot peak, oblique tears. Patient history according to the cause. If it is traumatic, you will have a history. Actually, knee examination we already finished in detail. We will now focus according to the to this lecture. But in real life, you will do systemic full history and examination. In the exam, you will do a full history and examination. Just we will focus here on the relevant information. For traumatic, you will have a history of trauma, but if degenerative, there is no clear history of trauma. Instead, there will be a recurrent history of pain and effusion. If traumatic, it could develop some sort of flipped meniscus to cause the main complaint will be instability, either in the giving way. Please analyze giving way, either rotatory or in straight line. Looking, is it true or false? As you will see, true or false looking, for example, because of hamstring tightness or pain, just few hours after injury. If there is hemarthrosis and you aspirate and inject, and you can do full extension the same as the other knee, this is a false looking. But if there is a solid extension block, this is a mechanical block, this is a true looking. Also later, when you do MRI, you will see something flipped inside the knee to cause this true looking. Examination, you start the examination of the knee by gait as usual, then inspect. Please don't ignore the alignment. Inspect from the side, front, side, back, and alignment is very important. It can, genovarum can cause of medial knee pain, not that degenerative meniscal tear. Then going into palpation after to the side of the bed, then supine on the bed. Supine on the bed, you start to palpate. Joint tenderness is the most sensitive test. Sensitive, not a specific. This is the most sensitive test. For example, if you have a test having 100 sensitivity, that means it is very good screening test. You wouldn't miss a meniscal injury, but in the same time doesn't mean that it is 100, not a specific, doesn't mean it is not 100% specific to the medial meniscus on to the meniscal injury. Other causes can cause joint tenderness, but it is sensitive, so a good screening test. Another tip, when you're doing, you can still have a locked knee in spite that apparently sorry, apparently you have a full extended knee, but when you compare with the other knee can hold 5 to 10 degree recurvatum, so it is just extended to neutral. Still you can have a locked knee. The importance of detection of locked knee, that in management you willing to wait so much time. There is an increased urgency towards the use of arthroscopy, for example. So, and if there is no locking, you can give him a lot of time, maybe up to 6 months, no problem, if the symptoms is minimal and decrease, and as you will see later. McMurray and Grinding, please review the knee examination lecture. Investigation, 4 views you have to do: 30 degree PA, flexion, weight bearing, X-ray, this is one. True lateral, notch, and patellar skyline, all to exclude sources of arthritis as a source of pain, and detect extremity and or any associated differential diagnosis. MRI, examination of the knee, history, proper history taking and proper examination of the knee is far more important than MRI. Anyway, there is a classification for MRI to detect meniscal injury. This is the normal triangular shape with low signal intensity. If you have a globular increased signal intensity like this, mostly degenerative type, and this is type 1. And here in type 2, it is linear, still not extended to the articular surface after either tibial or femoral sign. This is could be mostly degenerative, but could be a tear. Here, there is an extension down and extension up, or extension up. Anyway, if there is an articular extension, mostly it is a tear. If it is extended in multiple sequences, its incidence to being a tear far more and more. There is a radiological sign double BCL in bucket handle. This is an example of the tear extended to the tibial articular surface. This is the original BCL, and this is the flipped bucket handle meniscal appear in the sagittal view as if double BCL. This is bucket handle. This is one of the important viva image, and this is lateral meniscus. I don't see here the medial meniscus. You know lateral side and medial side by the presence of the fibula and the concavity. The concavity means it is medial side. If it is convex, it is lateral side. So the fibula is pointed up and lateral meniscus, lateral tibial plateau is pointed up. This is the lateral side. If you want for some reason to assess a post-operative meniscectomy or repair, you have to use gadolinium enhanced MRI, the same as lumbar disc disease, to differentiate between the avascular material and the fibrosis. Discoid lateral meniscus, one of the sources. If you have complete attachment between the anterior horn and posterior horn like this in multiple sequential sequences, this is mostly complete lateral discoid meniscus. The same, one can determine the lateral meniscus because of the presence of convex tibial surface and the presence of the fibula. For the sake of completion, patellofemoral joint can be assessed if you suspect arthritis or maltracking by CT differential diagnosis, all sources of knee pain. But please, arthritis and patellofemoral is one of the most important. Non-operative is the rule. Activity modification is very important. Non-steroidal physical therapy is far more important. Once you reach that acute pain and the effusion subside, you have to restore normal full range of motion and muscle strength. This is done by good quadriceps and hamstring, hip flexor and the abductor strengthening and stretching exercise. This is done if you have a patient with minimal symptom, no mechanical symptoms and minimal symptoms, and he is gradually improving, or all degenerative cases, or even in tears which are small, mostly willing to progress if less than 1 centimeter. In length, it mostly willing to progress. So operative management is the reverse. If you have, for example, looking symptom, mechanical symptoms, there is failure of non-operative management, you will go to the site of the operative management. 3 types: meniscectomy, partial meniscectomy versus repair. For the sake of completion, transplantation, meniscal transplantation. We took for the lateral bridge technique, for the medial plug, and the adequate sizing is the third information you have to know. In the Viva exam, don't mention this item except if the examiner asking you directly. Otherwise, partial meniscectomy, repair only. You have to discuss the pros and cons of each of them with your patient. For example, repair is a chondroprotective. Resection has a good prognosis, but isn't a chondroprotective. A uh, there is an arthritic changes develop later in years. In older age, there is an arthritic changes in the form of Fairbank changes. Also, you have to discuss with your patient about the location of the tear, for example, age of the patient. For example, if it is in the red vascular area, and the patient is young, mostly will benefit from repair. But for example, if more than 45, for example, and in the central part, the possibility of healing is decreased. If you do a resection, you have to resect to only as minimal as possible, only the unstable fragment. Unstable fragment means that when you are probing this fragment, you can't move it. Unstable means you can move it more than 1 centimeter. If less than this, it is mostly stable. Don't injury the menisco-synovial junction. The menisco-synovial junction is the peripheral part which is containing the main circumferential fiber, which is responsible mainly for hope stress mechanism. So partial meniscectomy, if the after discussing of the patient, the pros and cons of each of them, if the tear isn't repairable, you can do partial meniscectomy. 3 types, we all do partial meniscectomy. Partial meniscectomy that the peripheral rim remain balanced, remain intact, which contains the circumferential fibers at the menisco junction. If you disrupt this peripheral rim, this is subtotal. If you remove the meniscus totally, this is total meniscectomy. We are doing only partial meniscectomy. 80% satisfactory outcome, but there is Fairbanks radiographic arthritic manifestation in the form of osteophyte flattening and joint surface narrowing. As I informed you before, lateral meniscectomy is far worse than the medial side. It increases the contact stresses 2 to 3 folds. Meniscal repair, if you have a young patient less than 35 with vertically longitudinal tear in a red zone, this is the best candidate for repair. About 80% successful without arthritic changes later in life. Theoretically, if combined with ACL reconstruction, it increases the healing rate. This is actually a little bit controversial now. They claim that when you're doing the femoral and tibial tunnels, there is a lot of mediators coming through the blood, enhancing the healing of the meniscus. 4 main types of meniscal repair. Inside out technique means this is the gold standard. Means that you deliver the needle through the joint from inside and take it out under direct vision. From the medial side, under direct vision, you push the hamstring back and protect them through a tissue protector and see and deliver the needle. The same on the lateral side. You have to be in front of biceps to avoid common peroneal, there to avoid saphenous nerve. This is an example. This is tissue protector, and this is during delivery of the needle after direct visualization. This is the reverse, outside in. You're starting from the out and deliver in. This is another view. And all inside, you doing everything from inside and open in tibial plateau fracture. You can augment your repair by some biological method, fibrin clot prepared from the patient on self, or platelet-rich fibrin like this to enhance biological enhancement of the healing. Vertical matrix suture is the strongest type of the suture. Meniscal transplant, medial bone plug, because they are anterior horn and posterior are farthest away from each other. Lateral side you can use bone bridge because they are nearest to each other. This is the example of bone block of the medial meniscus, and this is the example of bone bridge of the lateral meniscus. Correct sizing of this graft in relation to the knee transplanted is the most critical step. Within 10% error can be tolerated. So 3 informations only I want you to know about transplant: medial side plugs, lateral side bridges, and correct sizing is essential. You know that proper history and examination is farthest more important than MRI. Except which one of them, please answer in a comment, and I will respond before the next lecture. Thank you so much.